After a very
Good
long
afternoon,
time.
ma'am.
Good afternoon. Good afternoon.
I'm back with so many questions, ma'am, today.
Please take your seat.
Thank you so much, ma'am. Ma'am, today topic is an ovulation PCOD, ma'am. So my YouTuber viewers want to know what is this and what it causes and treatments, everything. Shall we start, ma'am?
Yes, sure.
Okay, ma'am. Ma'am, first question, what is an ovulation PCOD?
Very good. Very important question. And approximately, you should know if a woman does not ovulate, if a woman doesn't ovulate, it means she's got an anovulatory cycle. It's not always that she does not ovulate, but she may ovulate, but this ovulation is not optimal to help her to get conceived. So we will call it ovulatory dysfunction. According to the WHO, there are three classifications for this ovulatory dysfunction and anovulation. The first category is called hypergonadism. Hypergonadism. It means their FSH is high and their estradiol is low. Hypergonadotropic hypogonadism. The second category is a eugonadotropic eugonadism. It means their LH and FSH are not so high, it's okay within a normal range, especially the FSH, and the E2 is just a normal range for this group. Most important group in this eugonadotropic eugonadism is a PCO, which everybody talk about. What is PCO? What is PCO? I got PCO. What should I do? Whether I'll be getting baby, whether I get conceived, whether I'll get married, whether I will get a regular period or no. All those things is basically coming under eugonadotropic eugonadism. The third category is a hypogonadotropic hypogonadism. It means FSH and LH low, and E2 also the estradiol is also low. These three categories are the mainstay of the basically the anovulation and ovulatory dysfunction.
Ma'am, it's a common thing here. It's a very dangerous thing.
It is common. See, if you consider the causes and the etiological factor and also the percentages of the infertile woman, so it is basically 30 to 40% of the patient they follow, they fall in this category of the ovulatory dysfunction and anovulatory. So how much I said? Approximately 1/3, up to 40%. So it is basically the commonest cause of infertility, commonest cause of irregular period, commonest cause of the lack of period is this anovulatory and ovulatory dysfunction. And in this category of anovulatory and ovulatory dysfunction, the PCO is the commonest. Again, I will repeat, the commonest cause of infertility, commonest cause of the problem in this irregular period, it is this ovulatory and anovulatory dysfunction and ovulatory dysfunction. A patient who does not ovulate regular, but she may ovulate and it is not regular. So it's called anovulation and ovulatory dysfunction. So let us say anovulation. She does not ovulate. So this is basically up to 40% of the women, they have this problem of anovulation, the patient who are infertile. So first thing, a woman come to the infertility clinic, if her husband's semen is normal, we have to search whether she is ovulating or not, whether she has a regular period or not. Before the treatment, I would have been very happy if you had asked me in these three categories where I mentioned to you, hypergonadotropic hypogonadism,
Yes, ma'am.
eugonadotropic eugonadism, hypogonadotropic hypogonadism. In this category, what are those pathology which is coming? For instance, in a patient with a hypergonadotropic hypogonadism, hypergonadotropic hypogonadism means their FSH is high and their E2 is low. Hypergonadotropic hypogonadism. In this, what is the commonest cause? Cough. premature ovarian failure, Turner's. Have you seen a girl come? She is little malnourished, she is short, her height is 4 feet, she doesn't have period. They are called Turner's syndrome. They are the one chromosomal problem. They have a chromosomal problem, 45XO or 46XX/45XO. That is a mosaic. Mosaic is a chromosomal problem.
Okay.
The PUF, premature ovarian failure. Some of the girls in a young age, like either basically she stopped period. Suppose she had period few years ago. She became 20 years and she all of a sudden her period stops. Then you take her FSH and FSH is very high. So she is a PUF. And what is the commonest problem in this PUF? Is a Turner syndrome. Her ovaries fail. Her ovaries becoming like a menopausal lady. This is the first category according to the WHO. The second category I told you, eugonadotropic eugonadism. That is a PCO. PCO, what is PCO? That also I will tell you after that.
Okay, ma'am.
The third category is those hypo. Both are hypo. Hypogonadotropic, hypogonadotropic. Yani FSH, LH low, E2 also low. What are those ones? The one who do lot of exercise. Anorexia nervosa. They are very thin, doubly, very thin, slim. They don't get period. Because that is a hypothalamic problem. That is a hypothalamic problem. That's it. So now you are asking me about how do you diagnose?
Yes, ma'am.
First of all, most important thing, by a detailed clinical history. Clinical history, she comes to us. See her age after age, the menstrual pattern. Whether it is regular, not regular. Is she trying to get conceived? Is she infertility? Or she is an anovulator? She is basically has come to us for the lack of period, irregular period, for what she has come. Based on this, then we will plan our investigation. If she is an infertile girl, we have to check the semen analysis, and then we have to check her hormone, see whether she has any thyroid problem, whether she has any hyperprolactin problem, or whether she has basically a PCO. How do you diagnose PCO? We have certain guidelines where we go as per the Rotterdam criteria, 2003 Rotterdam criteria, where 3 out of 2 criteria should be there, then we can label a girl as a PCO. What are those 3 criteria? One is ultrasound imaging of the peripherally placed a small follicle up to 9 to 10 millimeter, and there should be almost 10 to 9 of these follicles peripherally placed. This is one criteria. The second criteria, if she has a high level of the male hormone, her testosterone is high, or her DHEA or androstenedione high. The third criteria, if basically she has got a period which is irregular, or she doesn't have a period, amenorrhea or irregular period. Again, I repeat, if she has an ultrasound image of type of a peripherally placed follicles, which on ultrasound there should be 10 to 12 of these small follicles. Ultrasound image of the PCO. The second criteria, if her male hormone are elevated, androstenedione or testosterone elevated. The third criteria, if she has amenorrhea, no period or irregular period. 2 out of these criteria, if she has, it means she should be labeled as PCO patient.
Patients, okay.
The diagnosis, once it's made, what is the treatment? How do you treat PCO? PCO treatment depends on what problem she has got.
Okay.
Is she having only irregular period? So basically, if her BMI is normal and less than 23-25, we just give them progesterone or progesterone as and when is required. If period is missing, give them progesterone, get a period. If she has an infertility problem, then we have to induce the ovulation. Okay, ovulation induction agent, the best thing for this young girl is a clomiphene citrate. 50 mg we give up to basically 100 mg or up to 150 mg, and we will just do the follicular study. She may need a HCG injection. Maybe about few months she'll get conceived. Many of the patients, they will ask us what is the success rate of the clomiphene. It's only 10 to 15% per cycle. Each time she gets clomiphene, approximately 15% success rate is there. Cumulative success rate, if we give for 6 months the clomiphene, it's approximately 40% cumulative success rate. But clomiphene has a estrogenic property and anti-estrogenic property. Endometrium sometimes is poor, so we should be careful, and we have to do other things. Basically, time intercourse is there, or sometimes we do IUI to increase the success rate of the clomiphene. If patient does not respond to this, then the other next molecule is a aromatase inhibitor, and letrose we give them 2.5 mg for 5 days. If suppose she also does not respond to this, then she will be labeled as a clomiphene resistant. Means she does not respond to the tablet, the conventional treatment. And what to do? We have to maybe give them HMG. But HMG in this modern era of 2020, 2022, we are not supposed to give, because now we have a freezing facilities. Freezing facility, it helps if we give HMG and if we give FSH and she develops so many eggs. The best thing is to do the IVF and cryopreserve all these extra embryos, and then transfer her 3 embryo in a subsequent cycle for 3 or 4 cycle, and basically she will get conceived. Like that we manage this type of patients with PCOS. You may be asking what is the role of laparoscopy in these patients? Yes. Laparoscopy indication in these patients, yes, if she has basically a clomiphene resistant. If we think that associated with the infertility, she has maybe other problem, maybe she has got a chronic PID, maybe she has got a endometriosis, or maybe her age is more than 30, 31 years or 32 years age, she is getting a very long standing infertility, more than 5 to 10 years. So these are the kind of cases where we have to basically consider laparoscopy. If she already had her tubal assessment, and in spite of tubal assessment and multiple cycle of the ovulation induction, like clomiphene we have given her no success, letrose we have given no success, HMG we have given no success, these are the kind of cases where we have to give them counseling for laparoscopy.
Mashallah, we have so many options for treatment now.
Yes. I'll show you some photos where you can see laparoscopy was done in some other very, very good center, but they didn't get success. But when they came to us, in about 1 or 2 months, they all got conceived. So
we have done laparoscopy sessions, ma'am.
Yes.
With lots of success stories. Even I am the perfect example for that laparoscopy.
So many patients also, they